Can we start now, sir? It's 3 o'clock.
Good morning, Ma. Professor Grange. Yeah, I think it's time.
Yes,
time is
3 o'clock. Okay, we'll start now. Good afternoon, ladies and gentlemen, senior colleagues, distinguished friends. Welcome to the May 2022 edition of our meeting. And today it's my pleasure to introduce a good friend who started residency in Nigeria, in Lagos to be precise, and then decided to emigrate to the US. This is also an opportunity to say that we've been in touch all this while. He's always in Nigeria for one thing or the other, so he hasn't forgotten home at all. It's my pleasure to welcome Dr. GLADSTONE AIREWELE to present to us today. And in our usual manner, I'll hand over to the chair to say a few words before we commence. Thank you, sir. Welcome. Over to you, sir.
Okay. Good afternoon, everyone. I hope I'm audible.
Yes, you are, sir.
Okay. I'm very excited today for today's meeting for many reasons. The topic for today is a very, very important one for all pediatricians, especially for those of us in private practice. Not only because it's such a common condition, sickle cell disease, but because of the chronicity of it. So you will find that the patients stay with us for a very long time. And so we have to be on the top of our game in order to be able to meet the various challenges. And they always have challenges. And advancement in technology is changing many things very rapidly. So it is very important that we continually update our knowledge and skills in this particular area. And some of these children with sickle cell disease, even when they become adults, and you think that you breathe a sigh of relief that okay, they are going to physicians now. Many of them will still come back to you when they have difficulties because they are already used to you and they want to get advice from you on what to do. Yes, so it's very, very important for us to be up to date. And I'm so happy today that we have one of our colleagues who is in diaspora now. I think he's been there for about 30 years or so. And he's done so well for himself. He's a professor there. And he's in a hospital. I think it's the biggest children's hospital in the world, if I'm correct. Please correct me if I'm wrong, speaker. Texas Children's Hospital is a very big hospital, and their department, the department where he is world known, is world renowned for oncology and hematology. So we are very blessed today to have him with us here to to talk about a particular aspect of the management of sickle cell disease, where I think we need to educate ourselves a lot. Just to digress a little bit, where he comes from, the Texas Children's Hospital, is part of the Texas Medical Center, which is the largest medical district in the whole world. I had the opportunity of visiting the place many years back to the MD Anderson Cancer Center on a couple of occasions. And, it is a place that one needs to see. The Texas Medical Center is so large, it's a district on its own. It's like a local government here. And it has, I don't know, the speaker can fill me in here, but four or five teaching hospitals, 4 or 5 medical schools, several teaching hospitals, several specialist centers. It's almost like a town on its own. And the interesting thing about the place, why I'm saying all of this is that, you know, it is a not-for-profit organization. It's not owned by government, and it's not owned by private for-profit. It's a non-profit organization. And it was founded, according to the history, by a combined effort from a philanthropist and the government. So it shows what is possible when there is honest commitment from government. Government gave the land, I was made to understand, and the philanthropists gave the money. And they both agreed that this facility will not belong to government and it will not belong to the individual. So that kind of partnership is something that really we need to be looking at more in developing countries, because it has done so well. They started from very small beginnings, and it is interesting to read the history of that place. So I'm so happy. I hope the speaker will spend a little bit, because this picture he's showing us is very, very small compared to the town where he's coming from. It shows what is possible and what we need to learn from in developing countries, how we can partner together altruistically in order to improve the health of our people. So having said that, I will not take too much of your time. I will hand over to the coordinator, who will then continue with the program. Thank you very much. I welcome you all. I look forward to a very interesting and stimulating discussion. By the way, before I go, I invited Dr. Akishete, Annette Akishete, who is the Executive Director of the Sickle Cell Foundation of Nigeria, because of the strategic importance of that foundation to this discussion. And I hope she will join us. And if she does, I hope the moderator will kindly give her an opportunity to say a few things after the lecture. Thank you very much. I welcome you all.
Thank you very much, sir, for the presidential welcome and opening speech. So I'll quickly hand over to Dr. Akishete, Dr. Adeshaya Akishete, who is the moderator for this program. Dr. Akishete, over to you. Dr. Akishete, are you on?
I'm on. Can you hear me?
Yes, we can. Go ahead.
Okay. So I said, good afternoon, everyone, and good morning to Dr. AIREWELE and his crew from Texas Children. This afternoon, we'll be talking about sickle cell anemia, and precisely we'll be talking on the curative therapies, one of the many curative therapies for children and adults with sickle cell anemia. So by a way of introduction, Dr. GLADSTONE AIREWELE is an associate professor in the Department of Pediatrics at the section of Hematology-Oncology at the Baylor College of Medicine, and he doubles as a consultant at the Texas Children's Hospital. He had his medical education at unarguably the best medical school in Nigeria, the University of Benin. And then following which he proceeded to the best teaching hospital, the Lagos University Teaching Hospital, where he had some part of his formative pediatric training before then going over to the United States, and he had his fellowship and training first at Bay State Medical Center and then at the Texas Children, where he had his fellowship in Hemonc. And since then, he has been a faculty at the Baylor College of Medicine, Texas Children Medical Center. His research interest is majorly in sickle cell anemia, lymphomas, and leukemia. And today, Dr. GLADSTONE AIREWELE will be talking to us on the topic stem cell transplant in sickle cell anemia. Dr. GLADSTONE, please, you have the floor.
Thank you very much, Sheye, and to Sande Letu and to Dr. Lawal for the kind words. There's not much to add to what Dr. Lawal had, described. The Texas Medical Center is actually quite impressive, and there isn't much to add. Some of the numbers are mind-boggling. Recently read that about 110 to 120,000 pre-COVID at least patients and staff come into the medical center every day. The Texas Medical Center has 3 medical schools, over to 25 to 30 hospitals in a single space. And according to another statistic I found, if the Houston Texas Medical Center were downtown, in terms of office space, it would be the 13th largest downtown space in the United States, just the medical center alone. I mean, having that aside, today I would like to discuss the issue of transplant for children with sickle cell disease. I'm going to focus on the challenge or the conundrum that the decision-making presents, so that in a sense, I'm not focused on ending this discussion to say, oh, now you go do a transplant, but in helping to, as Dr. Lawal astutely mentioned, as pediatricians, being able to counsel families and share in the decision-making with them. And hopefully at the end, I'll be able to convince you that it's not a very straightforward decision. Before I start, I would like to take a moment to remember the sad event that happened not far from Houston two days ago, where 19 children and 2 of their teachers were mindlessly shot. And as pediatricians, I'm sure you agree with me that there is no justification. We declare that there is no justification for violence against children anywhere in the world. And that as pediatricians will continue to spare no effort in advocating for initiatives to protect children against violence from the people who they depend on and who take care of them. So as I mentioned today, specifically, I'll be describing the pros and cons of the different disease-modifying therapies that are currently available for sickle cell disease. I'll summarize the role of stem cell transplants in sickle cell disease. I'll outline the steps involved from getting a patient from a transplant, the before and after, the before, the during, and then the after. We'll describe some of the potential outcomes of transplant in sickle cell. But although these are the objectives, the main goal is to empower you to be able to counsel the family to make the difficult decision about whether or not to do transplant. As you would expect, transplant is it's very popular. As part of my job here at Texas Children's, we have a global hematology program that's currently active in several African countries, in Malawi, Uganda, Tanzania, in Botswana. And everywhere I go, we have training programs in some of these places and programs in these places. Everywhere I go, people want to talk about transplant. Oh, when can we do transplant? When can we do transplant? So it was quite gratifying a few years ago when I saw a newspaper article that was then followed with this case series or case report from the University of Benin, where they report on the first successful transplant in a low resource country, that is in Nigeria. What's interesting is that this feat, this accomplishment, it was is in a sense reflecting the yearning of the patients who have sickle cell disease in low resource, health resource countries, you know, because where I travel, says, oh, we want to do transplant, we want to do transplant. And you say, well, do you have a newborn screening program? No, but we want to do transplant. If we do a transplant for stroke, do you even do ultrasounds to find those to have stroke so you can prevent them so they don't have stroke? No. We just want to do transplant. So in a sense, it's a book by the topic where it says, oh, we want the last thing first, that I read a couple of years ago, and it's quite reflective. And once when I was in Morocco, in Marrakesh, I met the doctor who ran the transplant program there. I said, well, if you don't have this and you don't have that, you don't have that, how come you have a transplant? He then convinced me, and he had a lot of merit in what he described. It's like, oh, you know, GLADSTONE, transplant is the tide that raises all boats. Because if I can do transplant, then it means that we've improved microbiology services, molecular services, and all. So I'm hoping, you know, just this last 6 months ago, I was in Nigeria, briefly visited my institution in Idiaraba, met with Sheye Akinshete, and saw this beautiful new construction of a transplant center. And I'm hoping that this kind of transplantation in Nigeria will be the tide that also raises all boats. Specifically for the Benin program, the latest information I have, which was published, is that the program has so far done 6 transplants. All of them were 6 transplants for children with sickle cell. 4 of them, all of them are alive, 100% survival, but 2 of the 6 kids had rejection, meaning that the sickle cell disease came back. The authors of the paper that I read, this is from 2020, lamented the lack of the cost of the procedure as a limitation, the absence of molecular diagnostics, the shortage of trained personnel, all the kinds of things that you will be entirely familiar with. I declare that I have no conflict of interest in relation to this presentation to declare. So to continue, I would like to briefly start with a kind of like a brief history of sickle cell and to bring us to where we are today. As I understand it, long before the first patient who's recognized to have sickle cell disease in Western medical literature came from the Caribbean, a dental student called Walter Clement Noel, I understand that African groups have had Obanje and Abiku and have had some understanding of a disease that runs in families that causes recurrent pain. But focusing on this patient, a young man, dental student, fairly wealthy, stumbles into a hospital in Chicago. The house officer takes a history. These are his actual notes, Dr. Ernest Irons, takes a history, looks under a microscope and says, oh, I see these peculiar looking cells. So he alerted his consultant, Dr. Herrick, who then proceeded to treat the patient, gave him some iron, they gave iron and some other extracts and treated him for yaws, disease that I don't know too much about. And then this young man eventually graduated, moved back to Grenada, where he was from, where he practiced dentistry before he died at the age of 32. 7 years after he first presented, the first case report of sickle cell disease was reported in the Archives of Internal Medicine in 1910. As something, I don't know if any of the trainees in the conference, it's something that will perhaps be familiar to them. I was struck by the fact that Dr. Herrick didn't acknowledge his trainee. I was also struck when I read the case report that the physician described Mr. No as an intelligent Negro, at least 2 or 3 times in the case report. And I just was left with the impression that Walter Clement No must have indeed been a really smart gentleman. From the beginning in 1910, median life expectancy from in the 20s, in 1930s to perhaps in the early 1970s was dismal. Case report of peculiar cells, recognition that this was a hemoglobin difference, recognition that it was a substitution in the amino acid chain followed, but the disease was really poor median life expectancy, 10 to 20 years. And this situation didn't change much until the 1970s with the National Sickle Cell Act. I was also struck when I researched the history a couple of years ago that the National Sickle Cell Act was signed by President Richard Nixon. So at least the late President Nixon was good for some things. And so with the National Sickle Cell Act, it put money aside for research in sickle cell. From the National Sickle Cell Act, newborn screening was born in the early 80s. We then were able to recognize kids who have sickle cell disease and treat them before they even develop symptoms. The study of the value of penicillin started very early in life. Prophylactic penicillin given 2 times a day, proven to prevent death was also demonstrated. And the progress has continued. So from the 80s is the penicillin. In the early 2000s, I must not forget the value of Prevnar, of the pneumococcal conjugate vaccine. Later in the 2000s, the introduction of hydroxyurea in children and the increasing safety of ongoing blood transfusions. We know that hydroxyurea, ongoing blood transfusions significantly impact the phenotype, the severity of sickle cell disease. Hydroxyurea has been proven over and over and over to reduce the frequency of blood transfusions, to reduce the number of vaso-occlusive crises that kids have. In Africa, in some of the studies in East Africa, it was also proven perhaps to even reduce the mortality of children, even from with some suggestion of some protection against malaria. Beyond hydroxyurea transfusions, in the last 3 to 5 years, we've now had voxelotor, a new disease-modifying therapy that raises hemoglobins that's taken by mouth once a day. L-glutamine has been approved, and crizanlizumab, an IV medicine, is also been proven to reduce the frequency of vaso-occlusive crisis. But what is unique to these disease-modifying therapies, though, is that it's medicine that requires for you to continue to take it. And that is different from which is the reason why transplants are attractive to many patients. But how effective are these therapies? This study came out of Belgium a few years ago. It was a small study, only about 500 patients who were in Belgium. And the investigators looked at their patients through a registry and compared the outcomes, comparing those who were on chronic transfusions, those who took hydroxyurea, those who were on nothing, and those who had transplant. You will see that the chronic transfusion and the hydroxyurea group appeared to do better than the transplant. Although I must caution that this was in the early 2000s, the numbers were small and the follow-up wasn't extensive. So it may not be a study that was entirely fair to transplant. Another study that was published in the US, which was a study of pulmonary hypertension, was able to also look at the survival of children who have sickle cell disease in the United States. Today, a child who's born in a well-resourced country would expect to live to adulthood. This study demonstrated a 99% survival into adulthood, with some loss up to 95% at 25 years of age. So without doubt, the combination of hydroxyurea and the disease-modifying therapies will keep sickle cell patients alive. Although I show this really hopeful slide, it is not the whole story. Because although children have made great strides in the last 20 years in their care in terms of reducing mortality, adults with sickle cell have progressive disease with significant end organ damage. Despite hydroxyurea, the loss of lung volume is progressive in adults. A survey of 18 to 30-year-olds showed that at least up to 60% of them have evidence of proteinuria, which is evidence of nephropathy. There is documented neuropsychologic decline with loss of executive function, proven with brain MRI in adults. The repeated going to the hospital and all also leads to depression and anxiety and resulting potential for low health-related quality of life. So I talk about great strides in the care of children with sickle cell, but I also acknowledge that the damage, the progressive damage in adults continues. So just moving back to away from Europe or the US that I've been talking about into the real place where sickle cell disease is. This is the true map of the world, not the one that you are used to. This is a map that has been scaled to reflect every country according to how many babies are born with sickle cell disease every year. I live here. We do 2,000 to 3,000 new babies a year in the US, once a year. And I'm sure more than that number is born in Lagos alone. This is Nigeria. It's the biggest country in the world as far as it's concerned. Up to 150,000 children with sickle cell anemia. And this is the Congo, the DRC, and that's India. Unlike the story that I shared, the hopeful story I shared in the previous slides, unfortunately, the children in the places where sickle cell disease is mostly prevalent don't do so well. The most current estimates, a study I saw out of Nigeria in the Lancet sometime last year, estimated that up to close to half of all babies who are born with sickle cell do not make it to 5 years of age. Now that we've talked some about the hydroxyurea, the voxelotors, the blood transfusions, you recognize that the hydroxyurea requires constant monitoring. The patient has to keep taking it. Blood transfusions are effective, but they come with iron overload, come with significant allergy. And it's important to realize that the first transplant in a patient with sickle cell disease in the early 80s was a lucky accident. Excuse me. A child in Memphis has myeloid leukemia. He gets chemotherapy, acute myeloid leukemia, gets chemotherapy, he's in remission, and the doctors try to consolidate his remission with bone marrow transplant. And lo and behold, his leukemia went away, and he didn't have hemolytic anemia anymore. And so this is the way transplant for sickle cell was born. So exactly what is the goal for transplant? Transplant seeks to replace the stem cells, making sickle cells in a patient with sickle cell disease with one that makes normal red cells by engrafting normal stem cells such that the production of hemoglobin S is below a threshold that will cause disease. Because this is not leukemia, you don't have to get rid of the whole bone marrow. And because sickle cell, and because normal red cells outcompete sickle cells, because sickle cells have a very short lifespan, the normal red cells are 5-10 times longer lived. You don't need to completely replace the bone marrow with donor-derived erythropoiesis to get benefit from transplant. So I'll talk a little bit later about the concept of mixed chimerism and how even patients who have 20-25% donor-derived erythropoiesis do not have any clinical symptoms. So transplant's goal is to have enough normal stem cells to produce hemoglobin S below, to produce normal hemoglobin so that the hemoglobin S, the sickle hemoglobin, is below a clinically significant threshold so that the patient no longer has symptoms. In an allo transplant, a suitable donor stem cells is collected. Although bone marrow transplant is a common terminology, not all the stem cells come from the bone marrow. A lot of it is from the bone marrow, but increasingly stem cells are being collected at birth in umbilical cord blood, and sometimes it can be collected in peripheral blood by using pheresis, where there's a cannula on one hand, a cannula in the other. Blood is removed from through one cannula, spun through a machine. The stem cells are retained and the other cells go back to the patient. The process takes 2-3 hours and the patient goes home. Prior to it, the patient gets GCSF or some other agent to stimulate production. Not a lot of processing goes into the stem cells that are collected. In stem cells, in transplants from a sibling, from a relative, the collection, kind of like the bone marrow from a brother or sister, is done on the same day as the transplant is done to the patient. About a week, 10 days before the transplant is done, the patient gets what we call conditioning therapy or a preparatory regimen to prevent the host immune cells from destroying the graft. Prior to the transplant, the patient undergoes, at least in our hospital, the patient undergoes serologies, check for CMV, EBV, herpes simplex, toxoplasma. Also has donor-derived HLA antibody titers evaluated, extensive organ evaluations, brain MRIs, neuropsychological testing to assess cognitive function, GFR, transcranial Doppler, spleen scan. And so basically an effort to document baseline. Many patients who are coming to transplant have been transfused extensively, so there's an iron overload investigation too. Increasingly, that is with an MRI of the liver. Many patients will see the social worker or the psychologist or the child life to do a general assessment of anticipated stressors during transplant. During this process, I've had occasion once or twice to write letters to US immigration for the embassy in Nigeria, because this is not something that a family can easily do without support. Fertility evaluations are really important. For kids who are pubertal or pre-pubertal, we send them to either the urologist or the gynecologist to do egg preservation or sperm preservation. And for those who are pre-pubertal, testicular tissue cryopreservation or ovarian tissue cryopreservation is a research process that's currently ongoing. And many of the patients have had ovarian or testicular tissue frozen And a recent report from France reported on a female patient who had this frozen, and then later on, years after the transplant, was having gonadal failure. And then the doctors autografted the ovarian fragment, which had been saved. But that is mostly research. But for pubertal patients, they have their eggs cryopreserved or their sperm cryopreserved. During the transplant, after the transplant, there's a need to prevent infection, antibiotic prophylaxis. 6 to 12 months after the procedure, the child starts to get re-immunized for all the childhood vaccines. There is a mandatory GVHD prophylaxis, increasingly mostly involves the use of cyclosporine and methotrexate or mycophenolate. During transplant, there is a significant red cell and platelet infusions, generally to keep the hemoglobin greater than 9 but less than 11, platelets greater than 50,000 because of a history of CNS events, of hemorrhagic strokes that have happened. The doctors generally will then assess engraftment, check CBCs often. We will say that neutrophil has engrafted if 2 or 3 days of consecutive ANC, absolute neutrophil count, above 500. Usually about a week after that, the platelets also engraft, where the platelet count stays above 20 to 50, about 50,000. And so such that you don't need to give any more therapies. Much later on, when we do liver scans, it may be necessary, when you do liver scans, it may be necessary to do phlebotomies to get rid of the excess iron. In addition to checking neutrophil counts, the doctors also do chimerism studies, usually starting at about 1 month, then at every 3 months, and then once a year after the first year. And the idea there is to document the percentage of the cells that are derived from the donor. How do you pick a donor? First of all, the donor needs to be healthy. He needs to be able to withstand the collection. Anesthesia is usually involved when it's a bone marrow that's done. A common question comes is that, well, can the patient have sickle cell trait? Yes, 2 to 1. Most patients who donate bone marrow to or donate stem cells to their sibling for sickle cell anemia have sickle cell trait. So yes, a patient with sickle cell trait has equivalent outcomes to the one who does not have sickle cell trait at all. So either hemoglobin AA, so-called hemoglobin AA, or hemoglobin AS can donate bone marrow. Really important, the most critical part of that determines success of a bone marrow process is the HLA matching. As you recall, the HLA complex is a set of genes on chromosome 6 that are really important for the innate and the adaptive response. It's what helps us determine, it's what tells my body, no, this is self or this is foreign. And so that the significant HLA matching needs to be done. The class 1 and the class 2 HLA genes are the ones that are most important. Remember though that HLA genes are very diverse. The last reference I saw reports that at least there have been 5,500 different alleles that have been described in the class 1 set. That is, HLA A, B, or C, and about 1,600 in the class 2 group. In the second group, we say that the patient is a full match, at least for a sibling, if there is 6 out of 6. A 6 out of 6 is A, B, and DRB1 match between the donor and the recipient. And for unrelated matches, we say they're a match if there's an 8 out of 8. 8 out of 8 means that A, B, C, and DRB1. The testing is less extensive in the relative because if A and B match, C usually matches because HLA class systems are inherited as a group. But because of the way the HLA system is inherited, there's only a 25, in theory, there's only a 25% chance that one sibling will be a match to their, to a brother or sister who has sickle cell disease. Clearly, if there are two siblings, the chance goes up to about 44%. It's a conditional probability. Problem. And in general, HLA matching is done either by serology or by molecular methods where the DNA is used to sequence the gene. Serology has given way mostly to molecular methods. And so that determining the HLA match is one of the most important things that must be done. What if there is no HLA match? Usually you go to the registry. This graph shows you that the chances of finding a match in the registry varies by ethnicity and by race. While a white European has at least 75%, 80 chance of finding an 8 out of 8 match in the registry, a Black South or Central American or an African or Black Caribbean has about a 10, 15% chance. Why is that? Because there's not a lot of Black people in the registries. Actually, there's no registry in Nigeria. And secondly, on top of that is the fact that the diversity of HLA genes is so much greater in Africans compared to Europeans. Asians come in between. It's quite common when patients come, it says, oh, you have two siblings, they don't match. He says, oh, I need you to test my cousin, my uncle, and that. I said, no, if you have money to waste, sure, you can do that, but the chances of finding a full HLA match from a cousin or a person who doesn't have the same father and mother as you is slim. The only situation that I've seen is in cultures where there's first cousin marriages. You could then sometimes get a cousin or stuff. So because there are some cultures where routinely first cousins marry. Increasingly, we talk about haplotransplant. A haplotransplant is one where there's a 3 out of 6. You could get a cousin or a parent who is a half match. That is what is called a haplotransplant. On the whole, there's about 25 million people who are in registries around the world. And as I mentioned, the only active registry that I know that's in Africa is in South Africa. I mean, in sub-Saharan Africa is in South Africa. Although I saw a BBC report a few years ago that there is the beginnings of a donor registry in Nigeria, but I do not think that registry, if it's still there, has been linked to the national or the international bone marrow registry. What if you have more than one suitable HLA match? Then you do other donor considerations. If you have more than one HLA match, the younger donor is better. The female donor who has not had children is better. The bigger one, the one that matches the size. So if you have a baby, can't really donate to a mighty eagle because you cannot get enough blood, you cannot get enough stem cells to transplant them. And then if ABO mismatch is not an exclusion, but it will be nice if the ABO blood groups match. And if a person who is CMV negative, for example, there are very few of those, it will be better if you had a CMV negative donor. As far as the size goes, at Texas Children's, we will do only kids who are at least 1 year old or who are at least 10 to 12 kilograms can be donors. So in terms of terminology, I will immediately get rid of the syngeneic. Syngeneic transplants are where the donor is where an identical twin is a donor. Completely irrelevant for sickle cell because the identical twin here will also have sickle cell disease. Autologous transplant is where the patient is their own stem cell donor. And so that most of what we're talking about are so-called allogeneic transplants, where it's somebody else who's donating. An allogeneic transplant can be matched HLA, haploidentical, which is a half match, or can be completely mismatched. We already talked about engraftment and the concept of chimerism. A chimera is a Greek creature that has more than one genome, two or more genomes in the same organism. The Greek chimera is this creature that has the head of a lion, the body of a goat, and a tail of a snake. And I wondered whether chimeras are limited to Greeks, and I found out no. Yorubas also have chimeras. I read about Aroni. It's a Yoruba chimera forest god whose body is a human, has only one leg and one eye, and has the head of a dog and the tail of a dog. So Aroni and chimera, more than one genome. The concept is used in patients who get bone stem cell transplant by figuring out a way to determine, if we take blood from a patient, where is the blood cells from? How many of the blood cells were derived from the donor, and how many of it are the original native blood cells that are the patient? The lucky thing about sickle cell is that you do not need 100% donor engraftment to be cured, because as I mentioned, sickle cells have a shortened lifespan, and so the normal red cells outcompete them and reduce the risk of sickle cell symptoms. Chimeric estimates that use a lineage, a myeloid specific lineage, are the ones that are most accurate to predict whether there is stable engraftment. And it's generally thought that about 20 to 25%, only 20 to 25% donor engraftment is associated with the absence of symptoms. So you can cure somebody if they only engraft 25, 30% of the cells that are transfused. So we need to also talk about, you need to also know about the conditioning, about the myeloablative chemo, the non-myeloablative, and the in-between reduced intensity chemo. Currently, the European Bone Marrow Transplant Group, the American Society of Hematology, recommends that children should receive myeloablative chemo conditioning. And the most common combination of medicines is chemotherapy with busulfan and cyclophosphamide with a medicine to deplete T cells like ATG or alemtuzumab. This graph shows a series of conditioning regimens from the least toxic or least intense to the most intense. The patients who are here, I mean, this will be a non-myeloablative regimen. This may be a reduced intensity regimen, will be suitable for someone who is unable to tolerate intensive chemo, for example, an adult who is frail. And these regimens down on this side are the ones that are least likely to cause gonadal failure or to cause major toxicity. But the downside is that while they don't cause major toxicity, the graft is more likely to be rejected when you use non-myeloablative and less intensive regimens. In general, the field cannot fully agree on what is the most important indications, what are the appropriate indications for transplant. In the US, stroke used to be the most important indication, but now recurrent pain has overtaken stroke as the most common. The Society of Hematology currently recommends that only kids who have had stroke or who have abnormal TCD or with recurrent pain or recurrent acute chest syndrome should go to transplant. But the same guideline also says that, look, make sure you do the transplant as early as possible, early in age. Well, if you want to do it early in age, you shouldn't wait until they have a lot of recurrent ones. The European standard is a little more liberal. That one just talks about give a transplant for symptomatic sickle cell, preferably done before the child is 5 years old. 4-year overall survival for transplant varies according to age. This study that I found, kids who had transplant less than 5 years, 100% of them survived and 93% event-free survival. In general, the survival rates for transplant varies from 91 to 100% and 73 to 100% event-free survival. It's of note that younger kids do better And if you look at transplants that were done in the 1980s to the early 2000s, they do worse than the ones that were done from 2005 till now, and because the doctors just keep getting better and better at it. The most common reasons that people die are infections or where they developed graft versus host disease. And regarding graft versus host disease, data also shows that greater than 16 years, about 13–14% cumulative incidence. Less than 16 years, 14%. So 23%, 14%. So do it early if you can. What kind of donor? As I've mentioned, matched sibling is best compared to the others. What kinds of benefits would you expect? You may not be able to reverse damage that's already done, but the data indicates that you can stabilize damage. People who had stroke, who underwent transplant for stroke, do not re-stroke. When they have MRIs repeated, they do not have new lesions. The pain improves. Although there are a few patients who had a lot of pain prior to transplant, who may still be needing narcotics for a year or two afterwards. I've hinted at the toxicity, the infections, the graft versus host disease, the mucositis, and the 1 month to about a month or 2 to 4 weeks stay in the hospital. The 2 to 5% of patients who will reject their graft. The rate is even higher when the non-myeloablative and reduced intensity regimens are used, and the risk of gonadal dysfunction. A pubertal female going through myeloablative chemotherapy will be predicted. The majority will have gonadal dysfunction within a few years and will experience premature menopause. What about life expectancy and cancer? This study looked at patients who were transplanted for sickle cell or who were alive for more than 2 years. So limiting the analysis to people who are alive beyond 2 years is a way of removing the transplant-related mortality. If you see, although the numbers are small, the standardized mortality ratios for patients who underwent sickle cell disease is higher when compared to age and sex and matched controls. Regarding the risk of subsequent neoplasm, the numbers are small, so it seems like the risk is really low because the low number, but the standardized incidence ratios are higher than average. So the bottom line is that although transplants are considered a cure, patients experience better quality of life, the standardized mortality rate is a little bit higher. The standardized incidence rate for cancer is a little bit higher. Although these numbers are small, but in relation to thalassemia, they are much higher. And so we have to conclude that although sickle cell is a cure for sickle cell, the risk of late death is not negligible, and it's there. So having said all this, how does a patient decide? So a patient will come and says, oh, should I be transplanted? I hear that my quality of life will improve. Oh, but if I go in there, I'll be there for a month, and then for another year afterwards, I may not be able to work and all that. So how do I decide? Should I just do it, or should I wait to be safe and sorry? So the patient comes to you. I find that a lot of times the way the patients decide is based on this decisional dilemma. They decide it based on their perception and their past experiences with sickle cell disease, the culture from which they were raised, and maybe their financial, how much financially the burden that they may create. Personally, as somebody who grew up in Nigeria and who's lived in Houston now and who sees a lot of immigrants and native-born patients, I find that my immigrant families perceive sickle cell disease as much worse than native-born American patients. A patient may decide and say, well, I hear that I need to go do a transplant because sickle cell causes pain crisis. I have acute chest, I may have a stroke. But at the same time, the transplant doctor will tell you, oh, when you go to sickle cell, you may have GVHD, veno-occlusive disease of a liver, you may have myositis. And he says, well, how do I decide? I remember once, and you say, well, once I was in the Nigerian church and they were counseling people on marriage. This popular Nigerian church, they do sickle cell trait for all premarital counseling. And on this day, there was this discussion around, an anonymous question came to the podium. It's like, I just found out that my fiance has a sickle cell trait and I have sickle cell trait too. Should we go ahead? I can tell you that I was sitting in the audience and just listening. If I took a straw poll, it was overwhelmingly in favor of no, don't do it, do not tempt sickle cell. So which will be quite strange. And I've also experienced Nigerian families, for example, who are fundraising to go do a transplant in India, and then I call, I say, well, are you on hydroxyurea? No. Or they're taking tiny amounts of hydroxyurea. I say, no, I don't have time for hydroxyurea. I just want to fix this thing. And then the data on American patients indicates that 3/4 of patients are willing to accept a 5% risk of death in transplant, and that more than half of them are willing to accept a 10% risk that they will have chronic GVHD. I suspect that the percentage for Nigerian families, if such research is done in Nigeria, is probably higher. That more than 5% of, more than 75% of Nigerian families will accept a 5% risk of death during a transplant. So a family comes and says, I want to do a transplant because I could die from sickle cell. And then the doctor turns around and says, well, but you could also die from transplant. As hard as this seems, I've met a few patients who were really calm about this. A few years ago, I met this Nigerian family, newborn screen developed sickle cell. The first time I met them, the mom just straight out tells me, says, I reject this diagnosis. I do not consent because the Lord told me that my child is healed. And then every time she'll come, we will pray. I was forbidden from talking about calling this thing sickle cell. So all I did was to just say, well, there's this thing that you have to take penicillin for. And we went on and on like that until the child developed acute chest syndrome a couple of times. I did a HLA typing on the sibling. The child was a match. Took them to transplant. The transplant worked, everything's fine. And about 6 months later, I'm walking on the corridor. The mom calls me, says, see, my child is doing so well, he's doing well. And I say, well, he says, see, remember the first time we met what I told you, that God said my child did not have the disease? This is the way that, this is the way it has manifested. So the point of the story is that for some, having a child who is a match is providence. It's like God talking to me and they don't have a problem. But for most, we have to counsel them. We have to share decision-making with them. From time to time, I even introduce them to families who have been through transplant. You come, you say, well, the sickle cell could give lung disease and damage my kidneys and give me retinopathy. And then you turn around and say, well, sickle cell disease could also give you chronic graft-versus-host disease and give you premature menopause. Then how do you decide? I've had families who were so stressed out about this decision, they call me 2 times a week, discussing it. They schedule the transplant, then they cancel it, and then they come and they keep asking, and I keep saying the same thing. And I remember once, not too long ago, I playfully then called this dad aside and said, look, based on what we are saying, I think you are mistaking me. I'm a doctor. I'm not a clairvoyant, and I'm not a prophet. It seems like what you need is a prophet. And so we laughed, and then eventually the family went and did a transplant. What about the idea that what I've mentioned, that, well, if you are a child and doing a transplant, you do better. But then once you are thinking, oh, my child is only 4 years old, let me go do the transplant right now, then you read a newspaper story that says, well, gene therapy is coming, the treatments will be better in the future. How do you decide? This dilemma frequently paralyzes patients. But the one thing that I tell them is that, look, I'm not a prophet, and I can't tell you what's going to happen, but I know that all the patients that I've counseled over the years, most of them, almost none of them, has decisional regret. all of them come back and they're happy, and they're happy to be rid of sickle cell. Even some people who have chronic GVHD are happy to exchange GVHD with sickle cell. So I need to point out, to create some perspective, that transplants are rarely used. If you count all the transplants that have been done for sickle cell anywhere in the world, there'll be maybe 1,500, if so. And that's because most people don't have a donor. American families is about 15%, and I showed you the data around unrelated registry, and that alternative therapies like hydroxyurea are there. And the latest estimate of the cost of a transplant, cost using specific cost to charge ratios that American hospitals use, indicates that it's close to $500,000 to do a transplant in the US. It ranged from $400,000 to $800,000. And you wonder, it says, well, once I gave this talk in Uganda, and an Indian, and one of the doctors says, well, it only costs $15,000 in India, to which I said, that's not only, because the US GDP per capita, the way I look at it, US GDP per capita of 60,000, Uganda GDP per capita of $800, I would think that $500,000 for a transplant is so much cheaper than $15,000 in India in a $800 GDP per capita economy. So I would like to quickly end by talking about gene therapy, exactly similar to allogeneic transplants, the autologous transplant, but in this case, is the patient who donates. The blood then gets processed to remove debris and all that. The patient gets a stimulating agent to get the stem cells to circulate. They are filtered out of the patient, taken to a lab. And the gene therapy approach currently, the ones that are most active are either using the lentivirus. The patient told me once, oh, now you are using HIV to cure sickle cell. So it's using a lentivirus vector to insert a normal gene, a gene that doesn't, that protects against sickle cell, into the stem cells. And the stem cell is then returned to the patient. Similar to allogeneic transplant, the patient has to get conditioning chemotherapy. All the studies that are happening now use myeloablative chemotherapy. The only difference between the auto and the allo is that there is no need for GVHD prophylaxis. Apart from the study by Bluebird Bio that's adding a gene, there's another study by CRISPR Pharmaceutics and Vertex that is editing the gene by trying to disrupt the fetal hemoglobin silencer. So if you disrupt the gene that silences fetal hemoglobin, you make the patient a baby again, where they don't have sickle cells. But just before you say, oh yeah, let's all go get gene therapy, I can tell you that the gene addition one was suspended. It has registered maybe about 40, 50 patients so far. Sometime in June last year, it was suspended for a few weeks because a patient developed leukemia. Then the study was reopened in August. And then in December, the same study was suspended because an adolescent who was transplanted a year and a half afterwards developed non-transfusion dependent anemia of unclear etiology. So the study is actually quite, is still currently suspended. And that has given the opportunity to the genomic editing one to be recruiting patients because this one is suspended. And to point out that the same company that's doing the gene addition one just withdrew from Europe because they have a similar product for beta thalassemia major in Europe. And they and the European EU could not agree on how much they would charge. They wanted $2 million. The German government offered 900,000, and that was not good enough for the company, so they withdrew. So this is the FDA official, just sometime this last month, wondering whether we'll ever be able to get commercially viable gene therapy if each gene therapy product costs $2 million. And that's not to count the chemotherapy, the admissions and all that. So we're talking about expensive therapy. So just to conclude, is to say that hydroxyurea is feasible, is effective, and it works for most kids. That transplant is the only cure, but it has significant risk. But that there's not much evidence to guide the timing and indications for sickle cell for transplant in sickle cell. All the guidelines are based on low quality evidence because there has not been high quality randomized trials. And to say that the access to matched donors is a major problem in sickle cell, in transplant and sickle cell, and for that reason, there's been a lot of effort to develop other regimens that can use haplo, like parents or cousins, and that gene therapy with by genetically manipulating cells is a promising avenue that may become the standard, but the time is not yet now, considering the issues that we've had with the research. And with that, I'll end, and I'm sorry I went over a little bit. Thank you.
Thank you very much, Dr. AIREWELE. So we've listened to the topic, and Dr. AIREWELE has taken us down, how sickle cell came to be diagnosed, and then he honed in on curative therapy. Precisely talking about stem cell transplant, the pre-transplant workup, talked about the intra-transplant work, talked about one or two problems that are post-transplant, and then the academic challenges that have been on concerning sickle cell disease, whether to transplant or not to transplant. So we welcome questions and comments. So if you want, just raise your hand so that we can then call you to make your comments or to ask your questions. Thank you. So while we're doing that, I'll just like to invite Dr. Annette Akinshete. She's the CEO of the Sickle Cell Foundation of Nigeria. We'll just give her 4 minutes to just talk to us about what the Sickle Cell Foundation is doing concerning the interesting things Dr. AIREWELE has talked about. Dr. Akinshete, please kindly unmute and.
Hello, good afternoon, good evening, everyone. Thank you, Sheye. I hadn't expected to actually speak at all. I must really also thank Dr. AIREWELE, Dr. GLADSTONE AIREWELE, for that fantastic lecture, very, very illuminating, really. And a little dampening, if you don't mind, in the sense that for those of us just starting out, and trying to, in a way, also encouraging our sickle cell community to come along on this journey of bone marrow transplantation as a cure for sickle cell. As you can imagine, we've been inundated with inquiries and questions and all these things you talked about, the concerns that parents have. But more, I find more than 70% of the families are saying, let's just have the transplant done. Is a solution to all our problems. But and I also see that there are some families who have actually researched a lot and found that perhaps if we wait a year or two or even 10 years down the line, there'll be newer cures, newer remedies that are safer. There's also the question of safety, but I find the vast majority, the overwhelming majority, are ready to go straight away and have a transplant that's a solution to all the problems of sickle cell. And now I think Sheye might have been able to also speak to this, that in our protocol in the Sickle Cell Foundation Nigeria youth collaboration, we have a partnership, and our protocol is looking at children aged 5 to 17, under 18. So we're not going to be doing transplants for younger children or for persons who are who are 18 or older. And that, again, that's based on the, however limited, research findings that it's like a safe area, a safe margin. And I think you too, Dr. Gladstone, you alluded to that as well in your lecture. So our protocol we're going to stick to that age range. Our protocol also is keeping us restricted to just sibling donors. Sibling donors. Again, you also alluded to that. We're not going to be considering relatives, cousins, and so on. And as you also pointed out, we're in a culture where we don't really intermarry within the family, so we're not likely to get. We're not even considering it. Let's just keep it simple. We're keeping, in other words, really, we're keeping our protocol very simple. Children aged 5 to 17, under 18, and sibling donors only. So we're more likely to get the best 100% match. I don't recall all the terminologies for HLA typing and all that. We also in our center have the HLA typing facilities. So again, we have been getting a lot of inquiries for families who wish to even do their transplants abroad, but would like to have the HLA typing done with us. And I would be really glad to have you visit Dr. Gladstone AIREWELE, visit our the National Sickle Cell Center and our Bone Marrow Transplant Center when you are next in Nigeria. So we'll take you around. You can see. Hello. Yes, am I audible? Sheye,
yes, you are. Yes, you are. Yes, you are.
So that you can also see what we have on ground. The future is really bright in terms of what we're doing for bone marrow transplantation. And again, I would say the future is very bright, generally speaking, in terms of what the future holds for the sickle cell community. We have come a long, long way from 10, 20, maybe, yes, years ago, when it was almost a hopeless case. Besides, as a public health person, I know that out there in the public health space, people are much more amenable to talking about sickle cell. All stakeholders are more likely to talk about sickle cell. Families, mothers, I say for mothers more than fathers, because it's mothers that bring the children to hospital. We don't see fathers. And I'm more likely to tell you that my child has sickle cell, which was not the way it was when we had a big survey some decades back in Nigeria. At that time, people were hiding their children who had sickle cell. Nowadays, they come out and say, my child has sickle cell anemia. We even have Nigerian names, Yoruba names that are more appropriate than they used to be for sickle cell. So we've come, they rather describe sickle cell as sejedole. And for those who are Yoruba speaking, I think it means, it speaks to anemia, the anemia of sickle cell, unlike in the past when they would call it abiku, or if you are Igbo speaking, Obanje, or perhaps call the Arumaregun, which speaks to arthritis or things like that. So we've come a long way in that regard. And where we have reached, people also ask, like you also alluded, Dr. Gladstone, that, and I also as a public health person would say that in the pyramid of care, we look at the base of the pyramid, the most care for the most people, and you consider bone marrow transplantation as being at the apex of that pyramid, and you begin to ask yourself questions as, is it necessary? Absolutely necessary. You too said so, Dr. Gladstone. By the time you develop a bone marrow transplant system, you are developing everything around you. The entire system comes alive, and all the disciplines are developed alongside. The current post bone marrow transplant clinic is multidisciplinary. We're looking after patients who have already accessed bone marrow transplantation outside of Nigeria. But rather than have them return to all those countries, they continue. Dr. Sheye is very much involved in this, taking care of all these patients. And I tell you, a number of them have very serious complications. And we're learning from these and knowing the kind of things we must not do in our in our own transplant program. And our timeline is such that our first, and you also alluded to that, the counseling, the psychosocial meetings with families and so on are paramount. In other words, the care that you need to take at the forend, the beginning, the forend of the care spectrum is so important. As you're taking care of the patient is a whole person. has mental, social, emotional, aspects to their being. So it's not just the physical aspect we're taking care of. So at this time, while we're waiting for that first transplant to happen in the isolation room, that's not all there is to transplantation. So at the fore end, all the HLA typings, the counseling, the meetings with families, pairing with families who have already had the transplant experience, and so on, are happening as we speak. So, I believe, and Shea will actually throw more light on this, that the first transplant will happen later on in the year. But the list is a long list as we speak. But the good thing we're also doing is talking with government, because the limiting factor, one of the barriers, the main barrier, is the cost of bone marrow transplantation. And we are working with the Nigerian governments, and we have now more than 20 governors who have accepted to pay for transplant for their patients, for their indigents. So citizens of various states of Nigeria, their governments will pay for the transplantation. And so that takes care of the funding aspect for our patients. And I think there's so much to talk about. If I speak more, I think I'll take up the whole time. Thank you very much for the opportunity. Thank you very much, Dr. Gladstone, for that very eloquent lecture. Thank you, Shea, for the opportunity. Thanks.
Thank you, Dr. Akishete. So we've got two questions. I will read the questions in the chat, but Mr. Yodeji Akinola, kindly ask your question or make your comment. Thank you.
Thank you very much, sir. Good evening. Can I be heard?
Yes, you can.
Thank you very much. A huge thank you for the privilege of this opportunity. I have a quick question for Dr. Gladstone and also one for Dr. Akishete. For Dr. Gladstone, thank you very much again. Very lucid and informative presentation. I'd like to find out what's your experience with the ethical aspects of bone marrow transplantation, particularly with respect to the fact that we're dealing, for instance, with children who are under the age of consent. So with things like the risk of gonadal failure, parents get to make the decision for the child, for instance. Yes, there might be the opportunity for cryopreservation of genetic material and all of that, but what's your experience with respect to the ethical aspects, the child not being able to make the decision, as it were, that would affect them with respect to their ability to reproduce in the future? And then one for Dr. Akishete, similar or along the same lines. Our plans, fresh transplant sometime later in the year, but looking at our context, for instance, I mean, the most obvious thing to look at would be, say, for cryopreservation of eggs and so on and so forth. Where are we alluding to being able to provide 24/7 electricity to be able to store those materials? And what's the implication of that in our context? Thank you very much.
Okay, please hold, Dr. Gladstone, please hold your thoughts while I ask Dr. Gaya Jayobe to make a comment or ask a question.
Hi, Dr. Gladstone, brilliant presentation. I just wanted to ask, Nigeria being Nigeria, sickle cell disease being where it is, do you advise storing umbilical cord stem cells at birth? Considering that the parents, some parents will be intentional and going ahead, they know their genotypes, and they'll go ahead and decide to get married and have children. Would you advise them actually storing the umbilical cord, if you had the facility to store the umbilical cord for stem cells for the future?
Okay, Dr. Gladstone.
Okay, thank you. Yeah, so relating to the second question, do I advise the storage of umbilical cord blood? I will say that umbilical cord blood will be useful if the baby whose cord is being stored does not have sickle cell, with the intention of using it to cure a sibling who has sickle cell. So routinely, I will advise someone who has, who's a family with a child with sickle cell to store the umbilical cord blood of a sibling if subsequent pregnancies. And storing it could come with significant financial outlay. In Houston, the companies that store cord blood will store it for free if you have a sibling who could benefit from it. But in a sense, the data that I showed that the best results are from either cord blood or bone marrow. I mean, much better than peripheral blood stem cells. So that if the cost is prohibitive, I will say that, yeah, you have a child who's, you have a child who does not have sickle cell who could be matching, and you are the parent, you have both of them. The child will always be available, and you could always collect bone marrow stem cells. But if there's opportunity to store it, and it's and can afford it, yes, I would say to store cord blood for siblings who do not have sickle cell for possible use and for the ones who does. And for the first question regarding the ethics of transplant, I mean, that's a tough one, because I will say that society already endows parents with the right to make decisions on behalf of their children using the child's best interest standard. So, because I don't think we'll be having this discussion if a child who has leukemia, for example, if you had a child with leukemia and you say, well, I'm going to give you chemo and you may have the same kinds of infertility or gonadal failure, if we won't be having that discussion if a child has cancer, I don't think the discussion should be having just because it's sickle cell, because they are both life-threatening conditions. One is more noisy, comes with bells ringing, with anemia, bleeding everywhere. But the sickle cell one is equally deadly. It does it slowly, but it's equally deadly. What I did not point out is that although we talk about gonadal failure in after transplant for sickle cell, emerging data indicates that sickle cell alone, even without treatment, there's a study out of France that looked at sperm counts in men who'd never taken, young men who'd never taken hydroxyurea or taken any medicine. They do not have normal sperm counts. Women with sickle cell disease who have not had transplant are likely to have menopause at least 5 to 10 years before women without sickle cell. So you have a disease that affects fertility at baseline. Much of that data is not there, it's just now emerging. So it's a really complicated question, but I feel though that we've already endowed our parents with the responsibility to make these judgments on behalf of their children. And I think that a responsible parent looking at all the data should make these decisions, because sickle cell is a life-threatening disease.
Thank you. Dr. Akinshete, do you want to just a 30 seconds comment on the question?
If I got the question right, thank you. Though it has to do with power.
Yes, power, and then yeah, basically power. It was power.
Yes, and what?
Cryopreservation, yeah.
Yeah, about cryopreservation, maybe you speak to that, but it's not in our plans at this time. However, Luth has an independent power system, power supply, so independent from the usual NEPA, what we call NEPA. And that's where our bone marrow transplant center is domiciled. Having said that, we are also making all the necessary preparations for, and even at this time as we're speaking, we're getting the support of a number of companies for not just a generator, but also an inverter. And the third one is the solar system. So we have backup systems, backup of backups. So that's the best we can do for Nigeria that we're in.
Okay,
that answers the question.
Yes, so basically, I mean, Luth has 24 hours power supply, except for downtime when the IPP is serviced. And that occurs about once in 3 months. So it's a predictable power failure that you have there. With regards to cryopreservation, we don't do that routinely in our service. So what we have done is that we've spoken to 2 fertility centers in Lagos who have been storing eggs for those who do IVFs. And hopefully, if the terms are right, then they will be the ones to be, will be in charge of that cryopreservation. So it won't be domiciled in the program per se. It's going to be a third-party cryopreservation. So basically, the consenting will be between the parents of the recipients and the respective fertility centers who are doing that. I think that's basically it. The other questions in the chat box talks about costs and all of that. The average cost of the transplant will be in the range of between 14 to 17 million per transplant, and it will cover care for the first 100 days, as well as 3 months of antimicrobials into the post-transplant period. Every other cost outside that will be borne by the recipient. Now, the cost you pay is excluding if there is intensive care admission. So that is an added cost to whatever is paid. And so the cost will cover total body irradiation. It will cover conditioning, stem cell harvesting and infusion, and then cover some medications within the first 100 days. So basically, that's just about the transplant program. So thank you very much for listening. I would hand over to Dr. Eletu now to close the meeting.
Yeah, thank you very much, GLADSTONE. Well, we're not surprised. Thank you so much for taking out time to give us this lecture. And to all those who asked questions, we say thank you. But before I close, I just want to ask Dr. Mobalaji Lawal if he can say a few words.
Yes, thank you very much. It's been very enlightening listening to the speaker all the way from Texas Children's Hospital. And also comments from what is happening locally from Dr. Akishete. I thank both of them, especially the key speaker and also the moderator. I can see through all of these opportunities for collaboration. I mentioned at the beginning how Texas Medical Center itself was a product of collaboration, and how it started from small beginnings, and how it's now the biggest, largest medical district in the whole world. I'm happy that Dr. GLADSTONE will have opportunity of discussing with what is happening locally, and hopefully galvanize, sort of collaboration, government, foundation, teaching hospital, and come up with something that is feasible. We can do it. So on that note, I thank everyone for who has spoken. Thank everyone for their comments and contributions to the meeting. Over to you, Stanley.
Thank you very much, sir. So on behalf of the group, the private pediatricians in private practice, I want to thank each and every one of us for attending this webinar this afternoon. Sorry we went a few minutes above our normal time, but I'm sure we all understand why that has happened. It's a very interesting topic, and I'm sure we're all wiser now as to when we are asked, should we do a transplant or not? We are now guided as to helping to counsel our patients as to the right choices to make. So GLADSTONE, those years in youth emergency obviously has dropped off. And I'm not surprised that you're able to give us such an excellent lecture. Of course, like I say also, very soon we'll call upon you for another talk. And for those in the diaspora, please get ready, you will receive my calls because we want more people outside the country to also contribute to our knowledge. The next meeting will be on the 30th of June and we're likely to discuss something surgical. I'm sure we've all been talking about medical, so now we're likely to discuss pediatric surgical condition, and you'll get more information concerning that. So once again, a big thank you to everybody that's participated in this presentation. You will also post this on the usual YouTube network, so please watch out for those who've missed, and we can also share it with those who have also missed this presentation. Thank you very much. God bless you all. Bye for now.